Let's talk about iron deficiency anemia. Iron deficiency anemia is a microcytic hypochromic anemia in which we have the MCV less than 80. Iron deficiency anemia, it is decreased iron due to chronic bleeding. Example, GI loss, heavy menstrual period bleeding, malnutrition, absorption disorders, GI surgery, example, gastrectomy, or increase in demand, for example, pregnancy. This all leads to decrease in the final step in heme synthesis. Labs would show you decrease iron, increase in TIBC, and decrease in ferritin. And one thing here, TIBC is always indirectly in relation with ferritin. So when the ferritin is increased, your TIBC will decrease. When the TIBC is increased, you will have a decrease in ferritin. Inversely proportional. So they're inversely proportional to each other. So here you have an increase in TIBC and a decrease in ferritin. That's just a rough way to understand this or memorize it, okay? Increase in free erythrocyte protoporphyrin, increase in RDW. That means a lot of different shapes that are present in the bloodstream. RDW, so bone marrow is trying to make so many RBCs that it's just throwing out maybe some immature cells which are larger than the normal. So that's why you have the increase in RDWs. And decrease in RI, reticulocyte index. Okay. Microcytosis and hypochromiasis, which means increase in central pallor. Micro means small cells. Hypochromiasis, increase in central pallor. Looking at picture A. Let's just look at picture A. Do we even have the picture A? Where do we have? Okay, here. Central pallor and small cells. Symptoms are, you would have a fatigue, conjunctival pallor. Looking at conjunctival pallor here again. Look at this. Conjunctival pallor. Restless leg syndrome, pica, which is persistent cravings and compulsive eating of non-food substances. That's pica. Spoon nails, which is chylonychia, may manifest as glossitis, chiliosis, Plummer-Vinson syndrome, which is a triad of iron deficiency, esophageal webs, dysphagia. Iron deficiency is going to give you red beefy tongue, and red beefy tongue, which will with red beefy tongue, you will have esophageal webs and dysphagia. That's the Plummer-Vinson syndrome. So, looking at the labs, so there are stages of iron deficiency. So the first thing to go down is this stored iron. So what is the storage of iron? That is the ferritin. And like I said here, ferritin is inversely proportional to your TIBC. So when decrease in ferritin, automatically you will have an increase in TIBC. Right? And the way the actual pathway is, let me show you the pathways of that. It might stick more. So when you decrease the iron storage, which is decreased ferritin, what's going to happen is hepatocytes will sense that and they will increase in transferrin. And transferrin is the way that you look at TABC. Okay, that's the first thing to go, ferritin. Second thing is we have decrease in iron, serum iron decreases. Third, when the serum iron decreases, you have the person's saturation also decreases because the serum iron decreased. Third, you will have a normocytic anemia first, and then you will have fourth, microcytic anemia. Okay, so that's pretty much what we have for anemia. But the thing is, let's now also talk about how iron gets absorbed in the body. So iron is taken in the diet, like a food iron. Let me just do it on a page. Let's just do it here. Okay, so we have the food iron that is in two states. So either we have the heme iron or we have a non-heme iron. Non-heme iron meaning that is in the Fe3 state, and heme being Fe2 state. Fe2 is more readily absorbed, and Fe3 has to be converted back to Fe2 state to get absorbed, and that is done by the enzyme that is the ferroreductase that converts Fe3 to Fe2 state. And with the help of vitamin C. So this heme iron now gets into the duodenum in enterocytes. Let's just draw that here. To the channel called DMT1. This channel is called DMT1. So as soon as it comes in here, it gets stored within the duodenum enterocytes. It's called ferritin now because it's become stored. Ferritin. And that ferritin, there is another transport channel here that is called FP1, which is ferroportin 1. Ferroportin 1. So from here, from the duodenum, still we're in duodenum, guys. From here we go into the blood through this FP1, ferroportin 1. And in blood, this Fe2 now binds with transferrin molecules. Transferrin, which is the carrier protein for iron. From this transferrin now, from blood, we can go to storage states in most tissues. So let's just go to tissues. This transfer is going to take it to the tissue levels. Like it will, let's say most tissues. And also the bone for erythropoiesis. So Fe2 is going to go there, and Fe2 is also going there. And in most tissues, again, this iron will be stored as ferritin. And if it needs to be used in some many enzymes, cytochrome enzymes, then it's going to be utilized within the tissues. In the bone, that iron is going to go into erythropoiesis and form the RBC. Now, when the RBC gets turnover, RBC has a life of 120, it gets turned over by the macrophages and gets destroyed in the spleen. That iron doesn't just absorbed by the just goes into this blood and goes out. No, it stays within the body. That iron is now then taken up by reticular endothelial cells, for example, macrophages, and then again it puts back into the bone for erythropoiesis, and also keeps them within the macrophages for later use. Okay, so that's all the mechanism of iron. Now let's talk about a really important thing about hepcidin. There's another thing which is an acute phase reactant. Acute phase reactant meaning if there is an inflammation, you have formation of acute phase reactants. One of them is hepcidin. So normally you have an hepcidin which acts, and now this hepcidin normally, without inflammation, just think about hepcidin at the moment, it acts as a central regulator of iron hemostasis. So this guy is like, he's looking at all of the iron. He's like, okay, do we have enough iron in the body? Do we not have enough iron? Do we need more iron? Do we not need more iron? It's just a regulator, central regulator of iron hemostasis. Now, if you have increased iron in the body, or if you have inflammation in the body, you have increase in hepcidin. And if you have a decreased iron, or if you have hypoxia, let's just forget the decreased iron, but if you have hypoxia or decrease, not iron, but decrease in erythropoiesis, this leads to hypoxia, and decrease in erythropoiesis leads to decrease in hepcidin. So what is hepcidin doing? That is important. So hepcidin comes from the liver. Liver makes hepcidin. Let's just write there, hepcidin. And it inhibits, that's the normal function of hepcidin. When it comes, it's going to inhibit the FP1s, which is the ferroportin 1, which is on the duodenum in the enterocytes. That was a channel from which the Fe2s were coming out in the blood. So hepcidin inhibits these channels, the FP1s, and also it inhibits the macrophages to give their iron. And the macrophages also have the same channel that is called, again, the FP1, which is called, again, ferroportin 1. So basically the hepcidin is inhibiting the ferroportin 1, which is present on the duodenum, enterocytes, and also the macrophages. So now guess what? Now you can't absorb iron into the blood, although you have lots of iron within the duodenum, lots and lots of ferritin in the duodenum enterocytes, but you cannot absorb them. That means you have technically, basically, you have low iron in the body. and you have lots and lots of iron in the macrophages, but you cannot give them out into the bone or to other tissues. So you have macrophages. RBC has a life of 120. They're gonna get lysed. They will release iron, and that will be taken up by macrophages, but they will not be able to give that out. So you will have iron within the macrophages. So that's all the story of hepcidin. Okay, so let's now go back to our discussion, which was the iron deficient anemias. And these are the labs. First the ferritin is down, then the serum iron, and then you have the normocytic and then the microcytic anemias. That's all for the iron deficient anemia.